So till now we were focused on how to publish what we practice, and this talk will be on how to practice based on what we actually read in published literature. That is perhaps of more value and more interest to the majority of our members also. So evidence-based practice it was defined by David Sackett as an explicit and judicious use of current best evidence in making decisions about the care of individual patients. So far, so good. So we all aim to do that only. So why should we shift our practice further? I mean, we all think we are doing this. That is the problem. And real evidence-based practice improves patient outcomes and enhances the patient's choices about how he should be treated also. So, and it maintains our lifelong learning and up-to-date practice and prevents obsolescence. So there is a triad for EBM. It is not just collecting the best external evidence. You should combine your individual clinical expertise and patient values and expectations to that. What you get in toto is what you implement for the patient. That is evidence-based practice. And actually there are 5 A's or 5 steps of evidence-based medicine. That is ask. I'll go into the detail of each one of this. But whatever you do, the primary prerequisite is a spirit of inquiry in your clinical practice. You should be always curious about what next. Am I doing the right thing? Can I do it better, etc. So the first question is ask. Everything begins with a question. So the clinician who sees a patient, then an issue arises that presents a knowledge gap, and then a clinical question is there in you, but usually you don't address it, you move on the way you can, but you should be addressing that question, and that should drive the rest of the process. So I'm just going into the now next what I'm going to do is I'm taking an example from our practice. You know this PICOT format very well. So even as not only as a researcher, even as a clinician, we should be actually trying to phrase our doubt in this PICOT format if you really want to practice evidence-based medicine. So this is a common situation I'm taking. That is, you have a patient being posted for cataract surgery. He is having aspirin. He's had a history of CABG on aspirin. And we all know it increases risk of ocular bleed. We all, as surgeons, would like to stop it. But this patient is very anxious about stopping aspirin, whether it will lead to mortality or other risks. So, so can I really, as a surgeon, go ahead and continue with my cataract surgery without stopping aspirin? This is the doubt I have. How confidently I can do it? Will I do it for my relative or for my mother? That's the question. So how can I address this question in an EBM fashion? So I first frame it properly. I'm talking about an Indian adult with cataract. Whether I should continue aspirin, that's the intervention. As against stopping aspirin, that's the comparison. And the outcome is a safe cataract surgery with minimal ocular bleed. So I should be acquiring proper evidence for this. And that needs a smart and focused literature search. This has already been covered. The first slide is the secondary literature, and systematic reviews come highest in the evidence that you are searching for. What to search depends on what you want to know. See, if you are asking a therapy question, you have to go for RCTs or systematic reviews. If it's diagnosis, it's diagnostic accuracy studies. If it's a risk factor prevention you're looking at, it's a cohort study or case control. If it's prognosis, again, it's a cohort or case control. Now, where to search? You have n number of databases where you can search, and you should search using keywords, mesh terms, and Boolean operators. I'm sure everybody here knows what it is, but for a practitioner, it would mean keywords would be the easiest of this. And AI-powered search is, of course, there. I'll come to that later. Now, how to search? You should develop a proper search strategy. That means in your research question topic, you can split and you can make one concept from each part of the research question and then combine this using and or Boolean operators. That's the ideal way. Actually, that's the systematic way of searching. And then you can apply appropriate limits of language, publication types, dates, etc. And once you have a few articles that meets your guidelines, then you can save the best citations and refine on the go. So one practical, but this is what I do. If I have a doubt, I go to systematic narrative reviews first. And then I look for evidence summaries. And if the questions are solved, I don't look further. If the questions remain, I might go into the primary literature based on the references of the systematic reviews. So in this question of aspirin, if I went and searched with that research question, I went and searched all these databases. And I went for systematic reviews and RCTs because this question was about risk prevention. And the keywords I used was aspirin, antithrombotics, and cataract surgery. And the Boolean operator was AND. And this was the citation list of the shortlisted articles I got from that reference. ആറെണ്ണം കിട്ടി കഴിഞ്ഞാൽ ആറെണ്ണം എനിക്കെടുത്ത് അപ്രൈസ് ചെയ്യണമെങ്കിൽ എൻ്റെ സമയം മുഴുവൻ പോകും. So I want to further shortlist from the 6. So that's what's called a selection of evidence. And I went in for the first because it was a systematic review and large sample credibility that will be high on my list. But I didn't have access to full text as an individual. So this is a problem with literature search. Now this one was again a robust design, but it was done in Chinese people, so it's a different ethnicity. So that was concerning. This one is a good study in Indian context in 2025, but the problem is the journal was not really good. And the last one is very well written, precise, robust, and very recent also. Only problem is it is further down in the evidence pyramid. It's a letter to the editor, but all these are good in its own way. So I read through all these articles and I selected all these 4 articles. But then I must talk to you about AI. At this point of time, I feel like a fool because I can use AI and I can do all this in 1 minute. So but do I do that? At this point of time, I wouldn't. I would continue with my search and then go to AI, because you should be sure who is in charge when you use AI. If you're very sure, fine. Otherwise, you're playing with your safety and your patients. So that's where we are now. Now, can I trust this evidence? Now I have evidence, but I don't know, really can I trust it just because it's published? So how do I know that? I have, of course, all these checklists. These many checklists are there, but I really don't want to use it, or it's too tedious for me. So some questions are easier for me. That is for a practitioner. These questions are easier. Look at the sample size. Look at how the sampling was done, whether matching was done. അതായത് കൺട്രോൾസും കേസും ആ ഒരു കാര്യത്തിന് ഒഴിച്ച് ബാക്കിയെല്ലാം മാച്ച്ഡ് ആണോ, ഏജ് മാച്ച്ഡ് ആണോ, അങ്ങനെ കേസ് കൺട്രോൾ സ്റ്റഡി ആണെങ്കിൽ. Then are the measurements and tools validated by other studies? Was it properly blinded? Means bias ഉണ്ടായിരുന്നോ? These were how are the outcome measures discussed? These are the things, at least when we look at literature, these are the things we should be looking at. Bias. All these things can produce bias in a study, and there are certain techniques by which we prevent bias, that is sequence generation, allocation, concealment, blinding. These are all certain techniques. You see whether these techniques were used properly in the study. That's what you do. And of course there are tools, but that's for the editors. For a reader, you cannot use these tools for bias. You should be more, there should be simple ways. So these are some simple ways you can look at in the bias. Now, now this is about, in a therapy study, we are actually concerned about whether these results are applicable in our clinical setting. That means the size of the treatment effect, that it's a relative risk, odds ratio, numbers needed to treat. These are the things that are very important when you appraise a therapy study. Whereas in a diagnostic study, sensitivity, specificity, and likelihood ratios are most important when you appraise a diagnostic study. Whereas in a prognostic study, it's the probability of the outcome over a period and follow-up period that is most important. So when you appraise also, there are certain things, certain areas which are important in certain things. So that is what I wanted to highlight. So once in this case, in the aspirin case, I appraised using this Prisma and Consort are the real things to appraise that evidence that I collected. But I didn't do that, but that's what we should be using. And once the appraisal was done, an article I can safely say that cataract surgery under topical anesthesia could be safely performed without ceasing systemic aspirin therapy. So that is the conclusion I derived through this process in this case. Now, can I really apply this? ഇത്രയും കഴിഞ്ഞാലും നമ്മൾ അത് കൺക്ലൂഷൻ മാത്രമേ ആയിട്ടുള്ളൂ. Are you going to apply this evidence? That is where this triad becomes important. So ഇത്രയും നേരം നമ്മൾ ചെയ്തതെല്ലാം ബെസ്റ്റ് എക്സ്റ്റേണൽ എവിഡൻസ് കളക്ഷൻ മാത്രമാണ്. Now I am now sure that this evidence is reliable, but then combine individual expertise, combine patient values with that, then only I can apply that in real practice. So do I have the expertise for a topical anesthesia? Are my patients similar to that in the study population? Can this test, can I really stop aspirin in my setting? Will the cardiologist comply? ഇതൊക്കെയാണ് നമ്മൾ നോക്കിയിട്ടാണ് ഇത് അപ്ലൈ ചെയ്യുന്നത്. And actually there are tools to know ഈ കാര്യങ്ങളൊക്കെ ഉള്ള tools we can download, print, etc. and use also. And finally, when you apply, these are the questions you should ask. Yes, in this case, the studies I looked at, my patient was representative. Indian adult study, so it is representative. Does this evidence matter for your patient? Yes, very much. If I can continue aspirin, my patient's anxiety is allied, perhaps his morbidity and mortality risk is also less. Are you clinically confident? Yes, I can. And does the intervention fit into the patient beliefs? Yes, he was apprehensive, so stopping aspirin helps. So, idellam vechittana I apply. So, I can continue aspirin with scientific backup, enhancing confidence in a safe outcome. So, that's how I finally apply this in an evidence-based manner to my practice. Once I apply this, I one patient, 2 patient, 10 patient apply cheyam. But I should be evaluating myself in this process. That's called the final step of EBM. That is assessing and evaluating how your implementation of EBM actually works. So there are some questions for that, like how successful or satisfactory was the intervention to the patients? Would it be appropriate for other patients or other population? Could it be done differently or better? And patient-centered outcomes in terms of clinical and quality of life should be considered. This clinical outcome is a safe cataract surgery. Quality of life outcome I already mentioned. So in conclusion, what EBM is what I have already discussed. I don't want to add anything else. But what EBM is not, and this is what prevents the practice of EBM. I actually very senior doctors and EBM bullshit article published it. So why? Because they think that EBM is a threat that replaces your clinical judgment, negates your clinical experiences, and reduces care to certain rigid guidelines and ignores the patient completely. It uses all this. And the triad is what EBM is. So it is just using evidence to sharpen experience and support shared decisions. But there are various challenges to the application of EBM. All this time pressure, limited access, everything is there. So final slide, evidence in everyday care, eye care, is done one step a day, and it's possible. What you can do is, 1, frame clinical doubts as focused questions when they come. Don't forget that and sweep it under the carpet. 2nd, do a literature search and start with trusted summaries and guidelines. Skill up. Namalku verade literature eduthu appraise cheyan pattilla. So you have to skill up. All the practitioners have to skill up in their literature searching and critical appraisal. Simple tools can be used. Apps and point of care questionnaires. And increase share time with the patients to know their preferences and then apply it, and start small. Implement one small thing in your practice and audit the outcomes. Share the results with the team and with the outer world. You share, you publish, and you build a culture of EBM in yourself, in the department, and the fraternity. So that is how, that's the way to go. Thank you very much for your kind attention. So now we come to the, after the boring part is now over, and now we come to the interesting and exciting part. And the part where we celebrate and applaud the best of our people associated with KGO. So I invite Dr. Sumita to,
yeah, I'm here.
Yeah. Dr. Sumita to kindly announce our KGO Award, Appreciation Award winners for 2025. Yeah, that's, can I please, yeah. I'm sorry for that small correction is there. This, Madam Jyoti Madam is the top reviewer, and that one is the outstanding reviewers are Dr.